works.
Yeah. Fantastic. So firstly, a very good afternoon to everybody, and a massive thanks actually to so many operational colleagues. I can see there's 93 people on the call. If any of your organisations are as operationally challenged as we are down here in Cornwall, then I know time's a really precious commodity. So a massive thanks for taking the time to come on. When I was originally asked to do this, I was asked if I could put together a presentation just to talk about an introduction to NHS procurement for about an hour. Now, I'm a pretty big fan of procurement. I've spent the majority of my career in it, but I wouldn't sit through a presentation on procurement for an hour. So I'm going to try and keep this to about 20 to 30 minutes. In fact, they think the average human being struggles to concentrate beyond about 20 minutes. So I'm going to try and clip it to about 20 to 30 minutes. What that should provide us with, though, is some time at the end for me to ask or for me to answer any questions you may have. So in terms of time, it's going to try and keep it to about 20 to 30 minutes. I'll seek to talk a bit about who we are in procurement and what we do, why we do what we do, a bit about procurement processes, a bit about the procurement landscape, a little bit about stakeholders and engagement, and I'll finish with some summary takeaways, and then I'll take any questions, provided they're straightforward and easy to answer at the end. Thank you. So what is procurement? It's an obvious question, isn't it? So if you were to Google that, you'd come up with a pretty stock phrase like this, I imagine. So the role of procurement is to obtain goods and services in response to an organisation's needs. But the way I see it really is kind of a bit more fleshed out than that. So for me, procurement's role is to have products and services available in the right place, at the right quality and quantity, delivered at the right time, and on the best commercial terms. So particularly within the NHS, having stuff available at the right place at the right time is absolutely business critical. When we think about procurement, we think about it in three areas. We think about goods, so that would include things like medical devices, equipment, medicines, and non-medical consumables. Services, you could take, for example, IT services, consultancy and facilities management, and works, so things like construction and infrastructure projects. So procurement itself is an enabling function, so we're a bit like finance in that regard. People often think procurement is a kind of decision-making function. We're not really, and I'll come on a bit to why that is in a minute, but we're really an enabling function, so we help people get what they need and we help make things happen. And a really important distinction with procurement as well is that we actually don't hold a budget. So what a lot of people think about procurement is that we have a big pot of money to buy things with. We don't actually. We help other people spend their money. So firstly, a little quick bit about me. That photo there was taken just outside Sheffield Crucible before I went into the Snooker Masters last year. That was just a joke because I'm wearing a waistcoat, so snooker related joke. Very difficult to judge the temperature of the room when you're in teams. There you go. Thank you very much. A little laughing emoji. That sort of thing works when you've got people in a room, but when you're on video call, perhaps not so much. Well, I was interested to see actually at the start, you put up an old picture of me when I used to work at procurement. And it looked like the old version of me had eaten the new version of me, because the old version of me was before I went on a fitness and health kick about 3 years ago. I lost about 30 kilos, actually. I lost about 4.5 stone. So it was interesting to see the picture of me, what would have been about 7 or 8 years ago. So with that in mind, the past 18 years, I've been back in NHS procurement. I have spent the last 7 of those working in Cornwall. So I was fortunate and privileged enough to be appointed to lead the team here 7 years ago. Prior to that, I served in Plymouth, supporting Derriford Hospital, and prior to that I cut my teeth actually in Bristol. So I was brought up in Bristol, and I worked for Bristol and Western Purchasing Consortium and led clinical procurement across the 2 Bristol trusts and what was Western Area Health Trust before it was brought together with University Hospitals Bristol. So that's 18 years of NHS procurement behind me. Prior to that, I sold into the health service actually for about 7 years. And prior to that, I worked at national procurement level. So I worked national procurement left the NHS, sold into the NHS, and then came back and started working in procurement again about 18 years ago. In terms of other roles, I'm the de facto Director of Procurement for the ICS down at Cornwall and the Isles of Scilly. I'm a board member on what we call the Peninsula Purchasing Supply Alliance, which is a regional hub that buys across the peninsula. I'm a board member of the Southern Procurement Partnership, which is an informal network which reaches as far east as Salisbury, up as far as Swindon, sweeps round, captures Bristol, and then sweeps right round the southwest down to Cornwall. And I also support national programmes through NHS and the Central Commercial Function. I'm currently advising as part of a strategic supplier relationship management programme there. And I've just realised when I look at that line, that probably wins competition for the most acronyms that you could possibly have got on one line of text in a presentation. So what does that mean in practice? What that means is I've got experience of working at national procurement level, regional procurement level, and local procurement level. And I'll talk in a little minute about what that means for procurement more broadly. A little bit quickly about our service. So we're a shared service in Cornwall, which means we provide procurement across acute, mental health and community. The organisations we serve have a combined turnover of about 920 million, so just shy of £1 billion. So basically that's income and what they spend. Of that, about 300 million is non-pay. So about 33% goes to goods and services and works. The remainder goes to pay. You'll no doubt be aware, I think the NHS, in fact, when I was looking at some facts and figures for this, it used to be the fifth biggest employer in the world. It's now the sixth biggest employer in the world. Amazon has just jumped above. I think the NHS employs about 1.6 million people and Amazon's about 1.61. Top of the tree, if you're interested, is the United States Department of Defense, I think, who employ about 3.4 million people. But in terms of non-pay, that's the element that we would influence. Although increasingly actually in procurement, we're starting to get involved more and more in workforce, things like agency, clinical insourcing and LLPs. Of that 300 million, the influenceable element of that is about 122 million. So that's the bit that procurement generally get involved with. Why is there a big difference between the two? Well, the stuff we don't influence in non-pay are things like HMRC payments, tax, utilities, rents, NHS litigation authority. So basically fixed costs that we can't influence. That would be non-influenceable. So it's the influenceable element we're interested in. We process about 80,000 purchase orders a year in our procurement department, which works out about just over 300 a working day. So they're orders that we're placing on suppliers for goods and services. And of those POs, within that, there's about 350,000 order lines within those purchase orders. We also run a full inventory management team at Royal Cornwall Hospital, and they're the people that receive goods at the back door and make sure that they are where they are when we need them at the point of care. And in terms of the lines that we manage, we call those stock keeping units, which is a kind of retail term really, but it means individual product line. And we look after over 32,500 different product lines. And to put that in context for you, if you walked into an average big Tesco or big Morrison's or big Sainsbury's, so a big supermarket, they generally stock between 20 and 30,000 different SKUs. So at the hospital, we look after more SKUs than you'd find in an average big supermarket. And the value of that stock's about £9.5 million. So how we're structured in terms of our procurement department is we have a contracting buying function, we have a systems and compliance function, and we have an inventory management function. And what that means in simple terms is that the contracting and buying people, they identify what we need to run our hospitals and put arrangements in place for it. Our buying team order what we need when we need it and chase that through to make sure it's delivered. Our inventory management team collect it at the back door when it's delivered. and then make sure we deliver it to where it's needed within our hospitals. And our systems and compliance team manage all the systems that sit behind that, the infrastructure that sits behind that, and run all our compliance things like freedom of information requests and reports, which I'll come on to in a minute. So are we high performing? The metrics say we are. So I think people often think of Cornwall as being a kind of outlying function at the bottom of the country, but actually from a procurement perspective, we do pretty well. The model hospital data says that metric-wise we're good. The outlying metric for us in model hospital actually is we're expensive compared to lots of other procurement departments. We would argue that's a good thing. There's been a significant amount of investment in procurement here in Cornwall over the past 7 years. And that's borne out in things like we used to have what they called a procurement league table. So they compared all acute trust procurement departments with each other under a rake of different metrics. We, of the 132 trusts that there are nationally, our procurement department ranked 12th. I just noting there's a lot of chat coming up about people not being able to see slides. I don't know whether people can or can't see the slides, but tell me if you can't, or whether people are having individual issues. I'm getting some thumbs up. So some people can, some people can't. Okay, well, there seem to be more thumbs than there were messages, so I'll carry on. I can see the slides. Thanks, Nick. All right, that's enough thumbs then. Thanks, everyone. So we're on the procurement league table, we were ranked 12th out of 132 trusts, and we rank 8th best performing for the price we pay for the goods that we buy compared to other organisations. In terms of our corporate performance, we have to provide metrics internally within our trust, and they measure us based on the time it takes us to place orders and deliver things, and having goods available at the point of care. So we process orders routinely within 1 day, about 90% of the time, and we generally have about 98% stock availability where we manage inventory. So we're pretty good at what we do. Worth noting as well, we're one of 6 Scan for Safety demonstrator sites nationally. What that means in practice is that we have a full inventory management service deployed, so we can scan product and associate it to patient. So we can identify what's been implanted in people, where, by whom, at a touch of a button. So in the event that there's a product recall, we know down to individual serial and lot number what's been put in people, when it was put in people, and who did it. And we look after both revenue and capital, and finance colleagues on the call will be far better to talk about this than me. But broadly speaking, and please excuse me if some of this is teaching you to suck eggs, because I've kept it at quite a high level, but revenue is the funding we use to support our day-to-day operation in our hospitals, and capital is the funding we use to buy equipment, infrastructure, and for the upkeep of our hospitals. But from a procurement perspective, we're involved in influencing both. So why do we do what we do? So that's what we do. And there's 2 main reasons, really. One is around compliance. So the boring bits are that it's law. So as a public body, we have obligations to discharge legally from a procurement perspective. And the act that's wrapped around that is coming into force, called the Public Procurement Act, formerly known as the Public Contract Regulations Act 2015. I will not go into detail about that. You just need to know that there's law that sits over procurement processes governing how it should be executed and what might happen in the event that it's executed incorrectly, because there are remedies through law that can be executed against trusts if you don't discharge your procurement obligations correctly. Each individual trust will have its own standing financial instructions. You often hear these referred to as SFIs locally, and I'll talk a bit about ours in a moment. Why would you have procurement in place? Well, it's good governance. It ensures good practice. So we help manage things like conflicts of interest. So if we're running a tender process for something, we'll make sure that people that are involved in the marking, the scoring, and the identifying of the winning bidder aren't involved in those companies in any way, so don't have any shares in the company, don't do any work for the company, don't have relatives that work for those companies. But to state the obvious as well, it's kind of the right thing to do. So when you're accountable to the public person responsible for spending public money, it's important that you discharge those obligations correctly, so that we can be held accountable by the public for spending taxpayers' money in the correct manner. One of the questions we ask our own team routinely, and this might resonate with some of you who are in an operational space but not necessarily a clinical space, is what's the purpose of what we do? And we asked our team that actually when I took the team on 7 years ago. I asked them directly, what's the purpose of procurement? And they would answer with things like to save money. So when they said our purpose is to save money, I'd ask them, but for what purpose? Why would you save money? So the answer to that might be, so we can invest more money in doctors and nurses. And the next question is, but for what purpose? Why would you invest more money in doctors and nurses? And the answer to that question came back, well, so you can treat more people. And so we'd say, but for what purpose? Why would you treat more people? And you say, wow, that's a good question. So you can make more people better. Next question is, for what purpose though? Why would you make more people better? And somebody in our team at that point said, so you can improve people's quality of life. So for the last 7 years since I took the team on, we've held that close as our purpose in procurement, because I think it's easy as what's perceived to be a back office function. And I would say we're not a back office function, actually. And I think the same as our finance colleagues, our estates colleagues, our IT colleagues, our facilities colleagues, is actually we're here to improve quality of life for our patients, for our communities, for the people that we serve alongside at Trust, and for each other in our department. And what we've found over time actually is talking about that and having that held dear helps us with things like retention and recruitment, because we hope that people believe when they push cages around a hospital in our inventory management team and stock shelves, actually what they're doing is helping high quality healthcare being delivered, which is different from stocking shelves at Sainsbury's. Not that there's anything wrong with stocking shelves at Sainsbury's, it's just what we do is a different thing because it has a different purpose. In terms of procurement processes, tendering and contracting, you'll hear those terms bandied about. In principle, the value of what you're buying drives what process you need to deliver. So our SFIs, what we talked about, and law will determine how we go about tendering and contracting for goods. So at Royal Cornwall Hospital, for instance, this is what outstanding financial instructions look like. So if you're spending between £10,000 and £50,000 on something, we're obliged to get 3 competitive quotations. Between 50,000 and about 139, 140,000, you need 3 competitive tenders through procurement. And if anything above about £140,000, you require a full competitive tender process. And that's where the legal obligations under the contract regulations kick in. But if you're contracting for healthcare related services, they're captured under what they call the provider selection regime, which is a new regime which came in January. And actually there's a 0 threshold. So if we're contracting in healthcare provision, for instance, or a third party provider to help us deliver healthcare in terms of elective recovery, for instance, regardless of what the value of that is, we need to make sure that we follow the law laid out in the provider selection regime. So under no circumstances should requirements be split to circumvent the regulations. That's what's known as deliberate disaggregation. So what we mean by that is if you're going to be spending £50,000 with the same supplier on the same goods, you can't split that down into 10 different orders at £5,000 per order. You need to aggregate it up to make sure it meets the SFIs. And we do have something called a single tender waiver, which again is something you may come across. But here you use very much as an exception and where valid rationales provided. So valid rationale for using a single tender may be where competition doesn't exist in the marketplace. So quite often in medical technologies, when companies develop new medical technologies, they have a patent on them and they're the only provider that can provide them. Well, there's no point in going out and tendering for that, because there's only actually a sole supplier that can provide it. So if we can evidence that, we can waive the SFIs by completing a single tender waiver. But crucially, that has to be signed off and approved ahead of committing any expenditure to any supplier. A very quick bit about procurement cycle. This is something you probably go through in your own mind's eye, actually, if you were going to buy a new car, buy a new telly, any sort of major purchase. The first thing you probably do is you identify the need. So again, in my personal life, identify need, my car goes pop, I need a new car. So then you find out who might be able to supply what you might need. So I'd identify a number of suppliers that might be able to supply me with a new car. I'd work out how I'm going to choose between them. And the way we do that in procurement in the NHS is we develop what we call award criteria. So when we go out to market and tender, we'll tell suppliers the criteria on which we're going to make our decision. And in fact, within law, we're obliged to do that if it's under the public contract regulations. So we have an obligation to tell suppliers how we're going to make our decision. So then we get suppliers to make proposals against that that match our needs. We decide then against that criteria which provider we need to award to. We make that award, contract formally for that, and then the cycle returns back to the need again. So that in short and at a high level is how a standard kind of procurement or purchasing cycle would work. So in terms of what the procurement landscape looks like, at a national level, we have what we call the central commercial function, often referred to as CCF. And they're the function that look after policy, governance and support, and provide advice and support centrally to the procurement community. Nationally, we have a body called NHS Supply Chain. And again, many of you all have heard of NHS Supply Chain. And they provide lots of different things, actually, but principally they provide two different functions. They provide national contracts and frameworks under which we can purchase against. They used to run what they call category towers, which is something some of you may have heard of. So for a period of time, the contracting function nationally was contracted out into towers. That's recently been brought back in-house now into the NHS under NHS Supply Chain's direct control. And through some of those contracts, Supply Chain will purchase goods and hold them in, I think there's 7 separate warehouses. The one that services us in the southwest is based in Bridgewater. So for fast running, relatively low value goods, they will be stocked in big warehouses nationally. And then the second part that they do is they provide a logistics delivery function. So NHS Supply Chain, if you work in an acute setting, will generally deliver to you every day. And what they do is they pick and pack right down to ward or theatre level. And those goods will turn up on a cage, and then a cage will be wheeled up on a day-to-day basis, either by your inventory management team, porters, or whoever serves you from the back door. And then those goods will be put away on shelves, and that happens as a daily delivery on fast-moving goods. And then regionally, we have what we call the PPSA, which is the Peninsula Purchasing Supply Alliance. They're a regional body that serves us providing contracts at a regional level across the southwest. We have the Southwest Procurement Programme, which is a programme of work where we've been aggregating demand across 15 acute trusts. So we've delivered one project on that so far, and that's been about water services. And then we have the Southern Procurement Partnership. So where it says SSP, that should be SPP, which is this body I talked about that wraps around Salisbury, down to Bournemouth, round to Cornwall and up to Bristol. So the south, within the southwest, we have a very well embedded and a good heritage of collaboration on procurement. And then we operate also at ICS and local level. So that's the level that I manage. Or whilst I'm involved at national and regional level, that's under my direct control. And there's a big drive and push at the moment in procurement for us to be procuring at an ICS level. So historically, trusts have bought on their own, and there's a push at the moment from NHS for us to push to be purchasing more collaboratively. So what you're seeing is procurement functions coming together into more shared services across ICSs at the moment. So some you can see that's already happened in some. So it happened in Cornwall. Some it's in motion, and some it's not happened yet. But that's very much the direction of travel. And in terms of what that means for what we buy, we tend to segment products into what you would buy at a national level, what you would buy at a local level, and what you'd buy at a regional level. So, for instance, you would expect at a national level for commodity-based stuff to be bought there, things like paper, stationery, bandages, cannula, examination gloves. So that's the stuff that's generally procured nationally and held in warehouses. Regional level stuff, as I said, things like services, like water, perhaps waste. And then at an ICS level, you might be thinking about buying medical technologies, perhaps cardiac stents, perhaps orthopedic joints. And then at a local level, you get to focus on the stuff that is really pertinent for your individual organisation. And they'll often be things like big infrastructure projects and construction. So in terms of stakeholders, just mindful for time, where are we? About half past, good. So in terms of stakeholders, we have both internal and external stakeholders. Internal wise, we've got our clinical and non-clinical colleagues. So they're our end users, and they're the individuals that provide inputs into specifications of requirements that work alongside us when we go out to market to let us know what it is they need to run their services. We engage routinely as well with infection prevention and control, health and safety and estates to make sure that what we buy is compliant. And that in part answers some of the questions we get routinely, like why does it cost us £10 to buy a 4-plug off the procurement ordering system when I can walk into B&Q and buy one for £5? And the answer for that is the one you buy in B&Q for £5 doesn't meet public sector fire safety regulations. So if you have it plugged into a ward and it goes pop and burns the east wing of the hospital down, that's the reason you don't buy one for £5 from B&Q. So these are the people that advise us on purchasing decisions. Finance colleagues on the call, you'll be pleased to know you're a really important stakeholder for us. And the reason for that is that finance do manage the budgets. So we need to make sure that we're talking to finance to make sure that the money exists for what we're buying before we go out to market to buy it. And then we've got internal stakeholders in terms of our boards and committees to manage. And we do that through reporting and governance. Examples of that for us would be Finance and Performance Committee and Audit and Risk. And then we also sit on groups such as Clinical Products Procurement Group and Medical Equipment Procurement Group. So they're advisory groups that we would, if, for instance, there's an opportunity to save money by switching from one examination glove to another one, that's not a decision procurement would make. That's a decision we take to Clinical Products Procurement Group so we can get subject matter experts to establish whether the more cost-effective glove is clinically appropriate. If the answer is it is, then we'll switch. If it isn't, we won't. So externally, suppliers clearly as an external stakeholder for us, because they're companies providing goods and services. Regulatory bodies, so NHS England, Central Commercial Function, Care Quality Commission, and MHRA. And patients, actually, in procurement, we do talk to patients. We have patient groups, because ultimately they'll be the individuals that benefit or not for bad purchasing decisions from the goods and services which we procure, always on a balance of quality and cost. So crucially, how do we go about engaging with those stakeholders? So internally, my view has always been that we all form part of one team in the NHS. So we're all driving towards a common goal, which is high class, I would imagine, is high class clinical outcomes for everyone, and procurement has a part to play in that. So we work really, really hard internally within the trust in terms of relationship building, and we've done that by making sure we're really visible, by spending time listening to people, showing empathy. We routinely shadow operational and clinical colleagues. We like to spend time in theatre. And that's helpful for us as well, because I'm quite a visual person. So it's always really helped me to spend time, say, in theatres, because if I can see what we're buying, then it helps me to understand how better to make those buying decisions. But critically, it builds trust on both sides, because we've worked really hard to kind of try and dispel myths about procurement. The role of procurement is to buy cheap stuff, because that's not the case. In fact, quite the opposite. And also there's a belief the other way, which is untrue as well, which is that clinicians want to spec everything with gold taps. And that's not true either. Whilst clinicians will always want the very best they can to deliver the very best outcomes, actually, if we bring the two of us together, we start to dispel some of those myths and build trust. So hopefully now our colleagues within Cornwall, and not all, but most, trust us in procurement to make good decisions, and we trust them not to spec everything with gold taps. Critically, early engagement is key. So it smooths the procurement process. Where we come unstuck is where people come to us late in the process and say, we've got all this way with it and we now need you to retrofit it. Often people think if they come to us, we're going to put blocks in place and make things difficult for them. But actually, it's far more difficult if you get to the end of the process to unpick it all than if you engage us early. We can help smooth that procurement process through. And then in terms of our boards and committees, the way we engage with them principally is around reporting. So we provide routine reports on performance and to our finance and performance committee. There's lots of different methods of engagement now. This is one, isn't it? Presenting over Teams, which isn't easy. I'd rather present face to face, actually. And I have this belief about the NHS that the people that work in it because they're people. So we work remotely now since COVID. Actually, we work more from home than we do on site in procurement. But we make the effort as much as we can to get to site to meet with people, because I believe engagement face to face is still the right way for us to engage with colleagues, clinical and non-clinical, on site. So our external stakeholders, how do we deal with suppliers? We model that in the same way that we do with product segmentation, because it helps us to make sure that we're spending the right time with the right suppliers. If we spend lots of money with them, and if they're critical suppliers to us, we'll spend more time with them than those that we buy off once a year and that don't provide us with business critical equipment. And then from a reporting externally point of view, we routinely push data up to things like Spend Comparison Service, which is an NHS tool, which takes a feed of all our purchase order data and compares the price we pay for the goods we buy with other trusts. We have access to that tool, so that's super helpful, because we can go and put a product code into that tool and it will tell us the price that everybody across the NHS has bought. So what we've seen since that tool came in is a flattening of pricing. So historically, suppliers would go around and charge everybody different prices for everything. And that still happens, by the way, and there's reasons for that. But what it's allowed us to do is we can go on and see if somebody at the Countess of Chester Hospital is paying a cheaper price for exactly the same goods that we buy, and they're buying the same quantities of them. We can go back to the supplier and really legitimately ask the question, why are you charging them a cheaper price than us? So it's basically exposed variance in pricing across the NHS. And then I go back to patient groups again, because we do engage with them routinely on things like construction projects. We'll have patient groups wrapped around that and get their input into those. And then critically, when things go wrong, so if we've purchased products that have had an adverse effect on patients, then I have actually met face-to-face with patients before to talk about that, to make sure that we learn from that and that we don't make those same mistakes twice. So where are we? 2:40. So I was just going to summarize quickly and give you a couple of takeaways. I'm mindful I do talk quite quickly and it's been quite machine gun. So a lot of it will kind of wash over you, I'm sure. So I'll give you a chance to ask me any questions about it in a sec. But in summary, I've talked about what is procurement, how's it structured, why we do what we do, and how we do it. So hopefully that's landed for you. I'll leave you with 3 takeaways if I can. So these are the 3 things I'd like you to take away from the presentation. One, that actually we're here to help. So we, like I say, part of the myth busting that I'd like to try and get across here today is that procurement aren't here to block and stop you getting what you need. In fact, quite the opposite. We should be here to help you get what you want. But we're also here to add value. So when you deal with your procurement department, you should feel like they're adding value, be it commercially, from a risk management point of view, a supplier management point of view, whatever it might be, we should be adding value. And we're also here to protect your interests. So as agents of the trust and agents of a public body, you can be held accountable for decisions that you make. So if, for instance, you sign and enter into a contract on behalf of a trust, which you don't have the delegated authority to do, then that could come back to bite you. So we're here to advise on that. The other second takeaway, engage us early. So as soon as you identify you've got a need for something, speak to your procurement department about it. And thirdly, feedback to us, challenge us, and help us to improve. Because only by getting your feedback as colleagues that we work with and serve can we seek to improve. So thank you very much for your attention. I'm happy to take any straightforward and easy to answer questions that you might have. So I'm going to stop sharing at this point. Has that stopped sharing, Katie and Eva?
Yeah, it's sharing.
Fantastic. And it hasn't stopped sharing and now showing my desktop with a photo of me on holiday or anything, has it? Because I've seen that. No, it hasn't. Good. That's helpful. Because I've seen that happen with people before where they stop sharing and then it shows their emails and it's got the detail of their emails in it. So that's fine. So any questions, observations, feedback from anyone? Nick?
Yeah, I realised when you were presenting, I didn't know something around the tendering aspect of it and the thresholds for the prices that you shared. When I want to buddy up with another organisation to tender for something, then am I still bound by those threshold limits? So say, for instance, I want to put in £40,000 and the other organisation wants to put in £40,000 for something. Are we bound by the over £50,000 threshold, or a straightforward question? I thought
That's a great question. It really is. I know everybody always says that, don't they? Oh, that's a really good question. But actually, that is a really good question. So the answer is, within your trust, no, you're fine, because your standing financial instructions say up to 50,000. However, if it was if it was 45,000 from you, 45,000 from a neighbouring trust, and 45,000 from another neighbouring trust, whilst you appease your own SFIs, the aggregate value of the contract puts you above the public contract regulations level, or close to, so if you go above the 139,000, that's the aggregate value of the contract. So at that point, you need to make sure that you're discharging your obligations against the public contract regulations. So it's the aggregate cost of the contract.
So the other organisation is not a health provider or not an NHS organisation, but it is a public sector body, though.
Yeah.
They would still have the same thresholds then.
Correct. Yeah. So if it's local authority, for example, they're bound by exactly the same regulations because they're public contract regulations.
All right. Okay. Thank you.
You're welcome. Thank you. Lena?
Just to say, James, it sounds absolutely dreamy where you are, but let me tell you that the experience is not uniform across the system. And I think, I don't know if this is a question or a comment, it's a comment really, to be fair, but where I struggle is with some, it's not even, it's with some sort of generic, consumables, if you like, or generic goods, like, microwave for the staff room, a table for the staff room. And whereas I fully take your point that, the one you get from B&Q isn't to a hospital standard, I can, though, tell you like for like that the wireless keyboard that I've been offered from our supplier is exactly the same as the one on Amazon, just £10 more expensive. And never mind that, but it will take 2 weeks, whereas I can get the other one tomorrow. Not to mention a lot of back and forth form filling, negotiation emails, whatever. So I don't know. I just get the feeling that it's not standardized across the NHS how things should be. Certainly not everybody has your expertise and commitment. The other experience I've had, again, is that we've had quite junior procurement colleagues work on a really complex and unique construction project for us. And we felt that they haven't, for no fault of their own, just haven't got the background to procure, steel beams or flooring or things, it's actually for an outdoor hospital garden that will have patients on it and will be connected to critical care center. So we struggle a little bit with knowing, are they leading on this or are they serving on this? Because that's also been a tension, that procurement come in, then take it all over, don't keep us informed as a client, don't actually necessarily know any more than we do. Sometimes I find myself simply receiving forwarded emails from the supplier, and I don't feel that's adding any value. I mean, I can email a supplier as well as the next person. I don't actually need to go to someone else. So yeah, I guess just a bit of a rant. I don't know how helpful that is, but just to sort of say that it's not the same everywhere, and I only wish it was like you say. So, food some thought there.
So there's quite a bit in there, Lena. No, thank you. So a couple of things. One, it's probably not as dreamy as I make it out to be. So, and if you spoke to, I don't know whether there are any operational colleagues actually on from Cornwall. There might be. They might be put me right and say it's nothing like that actually. And so it's easy for me to come on in and talk, promote my service really well. But one thing you're absolutely right about is that it varies wildly. So my networks are really wide-ranging on procurement across the NHS, and it varies in terms of capability and capacity massively. And that is absolutely something we need to get sorted out. In terms of the standardisation bit that you raised is absolutely right. That is equally not as dreamy here. And I've challenged our own IT function back actually. So when I needed my laptop replacing recently, it gets refreshed every few years. I got an email saying, which size do you want? And I said, I'm not bothered. Why are you even asking me the question? You're the IT experts, not me. So my view is when you come in, you should get monitor, laptop, riser, mouse, not pick on IT, by the way. So it's a really good example, and keyboard. Give me what I need and I'll use it. But don't give me a choice about what color mouse I want, what size riser I want, what size monitor. If I've got a need for a different size monitor because it's an occupational health requirement, then fine. But actually 85-90%, just buy it and give it to me, hold it in a warehouse. And then you get over this thing, Lena, about I can walk into PC World, buy one off the shelf for 2/3 of the cost today, to actually the lead time 6 weeks and it costs 1/3 as much, which just serves to frustrate people. Couldn't agree more with your point about junior procurement people being on complex construction projects. Again, it's a problem that's endemic across the system. I made the point in the presentation that we're fortunate that we've had a significant investment in procurement here in Cornwall. That's for all the right reasons, I think. My view is that procurement generally across the system actually is still chronically underfunded if you compare it to others. If you compare it to other organisations, to other sectors, actually the NHS, in my view, is underfunded in terms of procurement and commercial services, both in terms of its capacity and its capability. So you need more people, but you also need more skilled people to deliver. So basically that's just a response to your observation, most of which I agree with, but it's not a solution. to it, I'm afraid. But Ramon?
Thank you, James. It's about the second step of the procurement cycle you've shared. Find out who might supply what you want. So what I wanted to ask you about this step is it possible to have some sort of conversations with potential providers so we find out more about what we want, or would that invalidate a potential future tendering process?
That is a really good question again. So generally what you'll talk about is what we talk about as like soft market testing. So I don't think there's anything wrong in principle, Ramon, with doing a bit of market testing where you come back and say, we spoke to a few suppliers, we've tested some of our thinking out, that we know there's a number of people out there that can do it. And these are some of those people. Where you start to drift into hot water is where you almost drift into a kind of piloting phase, where you say, and what we've done is we've started to work up what looks like a model with one of the providers, or one of the providers has been on site for 2 weeks and they're deemed to get a competitive advantage. But I think up to that point, no problem with that. The bit about finding out who might supply what you want from our perspective is the stage in the process where we put an advert out and call for what we call expressions of interest. Yes. The challenge, to be frank with you with that, though, is not all providers look at where we advertise business. So often you'll miss people. So sometimes the subject matter experts like yourself that actually know the marketplace, by talking to people and warming them up, you can actually point them to adverts as well and say, we're going to be going out to market for this. Make sure you're looking at Contracts Finder, for example. So I have no problem with that in principle. But there is a line at which you can cross where it blurs from we're trying to identify who might be able to do this to we've drifted into a preferred provider kind of territory. Does that make sense?
It completely does, yes. Thank you. Very helpful, James.
You're welcome. Joe?
Hi, James. Thank you. I'm the Assistant Director of Strategy at Harrogate and lead the capital team. So mine's quite specific really to sort of capital and building sort of suppliers really. So my question really is, can you outline when it's okay to buy off an approved framework versus the sort of getting 3 quotes? When is it up to us in terms of ease of process, speed of process, or is there sort of guidance over when we can use either of those routes?
Yeah, again, really good question. So it depends. The way I'd be looking at it, Joe. So if you were working down here and you'd phone me, one of the first questions I'd probably ask is what's the value. So if it's relatively low value, then discharging that against framework, not a problem. There are some advantages in going to framework in that you're covered by the terms and conditions of the framework as well, which are often better than going out and getting 3 quotes direct from the marketplace, because you quite often end up with the terms and conditions on the quotes that you've been sent rather than the framework terms and conditions. But I'm kind of confusing the issue. So you can get some comfort by going direct through a framework. My position in terms of advising people, I would always advise people to get quotations. I'd always advise people to compete business where they've got the time to do it. And that can be done against framework, of course, as well. So the ideal situation is to marry the two up probably and say, rather than getting 3 quotes direct from the marketplace, I get quotations under the framework, and then you are covered by the framework terms and conditions, but you're also assuring yourself of good value for money.
That's helpful. Yes. Is there a value that you can't go to framework, or does that not apply?
Yeah, no, there isn't a value that you can't go to framework, but there's a value at which it depends how the framework's constructed without getting into too much detail. But if you're over that £140,000, which routinely I imagine in your world
yes.
you are, then you should really be competing that against a framework. Where an existing framework is in place for what you're looking for, we're being driven increasingly actually to procure from framework rather than direct from the marketplace. So going to framework is the right thing to do, but competing against framework is the absolutely correct thing to do.
Okay, that's helpful. Thank you.
No problem. I'll just have a quick look in the chat. Okay, is there any questions in the chat? Don't know whether Katie and Aoife have been looking in case anything came up.
There's one asking, out of interest, do you use any technology or software to help?
To help, full stop?
I think so.
Absolutely. How long have we got left? 4 minutes. So we have a rake of different systems. We have an e-tendering system. So all of our tenders are managed electronically. We have electronic contract database where we keep records of all the contracts that exist across the trust. We have access to spend comparison service. We have access to something called Procurement Dashboard, where all our data goes into, and we can see at a trust level who's buying what, where, when from suppliers. We have an inventory management system. So we've a 32 strong inventory management team, and that's underpinned by a system called Atticus. So we can tell you, so when I said we manage 28,000 SKUs and a £9.5 million stock holding, my head of supply chain was able to tell me the answer to those two questions within seconds. So when it comes to end of year stock takes, we used to have to employ somebody to come in and count all our stock. And now we say to the inventory management team, what's our stock holding? And they go, hang on a minute, £9.5 million. And that's how quick it is. So we use systems. So absolutely we use systems for all of those things. And then very, very finally, we're currently engaged with our robotic process automation team within our IT division within SITS, Cornwall IT Services. So they're helping us pilot looking at how we might be able to use robotic process automation in terms of our catalogue management. So we're looking at very, very quick example, because I know you probably all got to go, but again, for operational colleagues, it might be worth thinking about this. So there's a lot of routine tasks that we use in catalogue management. So for instance, every year we'll send our current catalogue to the supplier and say, have any of the prices changed? And they'll email us back to either say, yes, they've gone up, yes, they've gone down, or no, they've stayed exactly the same. And currently one of my team gets the spreadsheet, puts it in an email, sends it to the supplier sends it back to them, they look at the response. If there's no change or it's within our tolerances, they reload it. And we're looking at whether RPA can actually pull the file, email it to the supplier. Then if the supplier emails back, for instance, and says nothing's changed, which actually the overwhelming majority of them do. So if we put an algorithm in that says nothing's changed, the system will just automatically reload it with no human intervention. So what we can then get is our catalogue management team managing the exceptions rather than everything. So rather than them inundated moving spreadsheets around, we can actually get them negotiating prices where people seem to put their prices up. Does that make sense? So we're trying to, people get really worried about things like RPA and AI and artificial intelligence, thinking they're all going to come and take our jobs. But actually what we're doing is trying to get them to do the jobs we don't want to do. So what are the non-value added tasks that are happening day to day in procurement that human beings, frankly, shouldn't come to work and have to do every day? Because human beings are better than that, right? I don't want to come to work every day and move spreadsheets around. I want to come to work every day and add value. Not that, moving spreadsheets around might be adding value, but that's not really a task that human beings should be doing anymore, in my view. Okay. Hey, I realised, as I said, it's a finance thing, isn't it? I shouldn't be mentioning spreadsheets. All right, look, if there's no more questions, if you think of anything, I don't know how these things work generally, but if anybody goes away and thinks, I wish I'd asked that, or I didn't want to ask that, but I want to ask it now. Do they feed that to you guys at One NHS Finance?
Yeah,
Ethan and Katie.
if
And then
anyone
if you
has any
send it to me,
questions, yeah,
I'll
we
do my
can
best to
email it.
answer them.
Great. Thank you very much, James. Thanks everyone for joining today.
You're welcome. Take care, everyone. Look
Thanks
after
so
yourselves.
much, James. Fab session. Thank you.
Cheers. Bye-bye.